aware of. Some of the things that we'll highlight today, we'll talk about social determinants of health, our third-party administrator, WellPoint, really looking at the FCS services for housing and for employment. And then Kimberly will kind of take a bit of a deeper dive into some of those additional FCS programs. Looks like we need to kind of edit that one because GlidePath is no longer around. We've been so busy we haven't been able to do some editing, so it's another note to self. And we'll talk a little bit about becoming a provider. So that definitely, hopefully, we'll answer some of the questions here today that you might have about that. And definitely, hopefully, we'll have some time for questions and being able to some considerations and tips on how to start those intentional services. That you have a strong program, just like the gentleman earlier today asked, what are the different evidence-based practices and how do we use the FCS trainers to really help us develop a program? So I love that intentional piece when folks are here to kind of use the tools available to really build something unique for your organization. So for me, social determinants of health, health-related needs are a really critical piece when we think about the services. As people utilize the FCS assessment form to get authorization for services, we're really looking at some of those barriers and limitations that somebody has to receive services. Sometimes that's not having a safe place to live, or not having a safe place to be, or maybe you're not able to be employed. Maybe there's some educational deficits. Maybe you're working with DOC or recently released from an incarcerated facility. There's a lot of different things that could be negatively impacting somebody's life, and how we as our FCS community can connect people to resources, start that system of reigniting that sense of purpose that somebody might have, whether it's giving back to the community, creating a career path, starting with education, building a community around them so that they can develop some social connections to make life more balanced and enjoyable for those. So definitely there's a lot of different things that come into play. And I talk about this because in some of our other trainings with Medicaid, we really want to tie in some of these barriers and look at that medical necessity piece. So definitely I like to talk about social determinants of health because it impacts the lives of our FCS beneficiaries, but also it can really help us craft service plans, treatment plans, SMART goals for folks, and tie in, the golden thread for documentation for folks. Go ahead to the next slide. So we have a rich history, and I think it's on the next slide that's kind of a little bit overwhelming, but it really talks about the history of the Medicaid waiver, that this started, back in 2011 with the Washington State Legislature, and really focusing on things that can improve our participants' lives through the Medicaid services. So definitely, we really talk a lot, and I use the word a lot, intentional services to support folks. I think there's a lot of programs that really do demonstrate some innovative ways to provide services in the community under the Medicaid waiver. So it's really a joy to see the different ways organizations look at the benefits of the FCS program and being able to provide those community resources to help people on their journey to wellness, safety, stability, and thinking about next steps, whether it's a career, education, or safety. We really focus on CMS. It's not Kimberly and I coming up with this idea of the waiver and medical necessity for notations. It's really the Center for Medicaid Services. So we really encourage people to attend our Medicaid trainings, and be getting used to some of the language that we use, because it's really a core component, required component, that we're providing services that align with the Medicaid guidelines, and that the services we're doing are improving somebody's lives in some way, and be able to document that in contact documentations. And this is a really unique way that the HCA is really able to expand behavioral health services through the Medicaid transformation project. When I was in my previous role doing support employment program in the 90s, we didn't have a fee system for employment services. So this is a great way to really focus on those services and support people for employment and supportive housing. Anything to add, Kimberly?
My mute didn't want to come off. I think, there's nothing to add really other than we're in a unique space. Washington State is one of the first 3 states to provide this type of services through the 1115 waiver. And so we are kind of frontiering the way. We did, start this work early on in 2011, and I'll go through the timeline here in a minute. Actually, maybe this is a better slide. It's overwhelming a little bit, but in
Yeah.
2011, I know it's so hard to read, but also it gives you a real scope of where we came from, right? So although the slide is horrible, I'll try to break it down. So in 2011, we were given a SAMHSA 5-year transformation grant for what was called the Porch Project, Permanent Options for Recovery Centered Housing. And I actually had the honor of being a case manager in the Porch Project. It was granted to 2.5 counties across the state. So Chelan, Douglas, I always count Douglas as kind of a half county. If you're from East Wenatchee, I apologize. And Pierce County. And so we had these group of folks, and the idea behind these pilot projects was to show that people could be served staying in their community and have someone that would support them at home where they are or finding home so that they did not have to go transition out of their community to be served. And so that's where Porch originated. It was a supportive housing program. We went out and did home visits, outreach, all the things. And that led us to be able to build the case data-wise for supportive housing benefits in Washington State. And we had a couple other pilot programs such as bridges and HARPs, and we still have HARPs to this day. It's actually expanded since it started as a pilot. And then if you look a little bit further in 2013, we had our first supported employment pilot project, which was called the BEST grant. And I can't remember the acronym. Darren, do you know the BEST acronym? No,
I
okay.
do not.
I can't remember it. Anyway, but we had that to start kind of showing the data, using the evidence-based practices with both housing and employment to see if we were actually going to get outcomes that we desired for folks. So for housing, we use the PSH evidence-based practice through SAMHSA, and we use the IPS model through Westat or Cornell. I always forget like which one was first.
What's that?
Westat started it, and then so IPS is very researched, very much a ton of data-driven information to be able to provide good quality services and employment as well. So once these pilot projects kind of showed the outcomes of what we were getting for folks, when in 2013 the state was legislatively mandated to provide promising practices or evidence-based practices in our programs, we knew which ones we were getting outcomes through. And so when FCS came along in 2017, which is when we applied for the waiver, we knew that IPS for employment and PSH from SAMHSA would be the models that we would embed into our programming. So 2017, we were approved for our 1115 waiver. January 1 of 2018, we launched the Foundational Community Supports Program. And we're a few months after 8 years strong. So we've been around a little bit, we've learned some lessons, and here we are today applying for our third waiver here soon. 2028 is when we would be looking at a new waiver. And so those kind of how FCS came about is we had a lot of projects. We had to prove kind of what we would do, how we would do it, to be able to show CMS, Center for Medicaid and Medicare Services, how we would be able to provide these services effectively in Washington State. And one of the things we did differently than some others was decide that we were going to use non-traditional providers that weren't necessarily just behavioral health to provide these services so that we could have folks in housing and employment programs, peer services, all those things, being able to provide supportive housing and supported employment. So we are currently in our Medicaid Transformation Project 2.0. This is kind of how it's been it was a beautiful graphic to show kind of all the different things happening. FCS did have some changes when we got approved for MTP 2.0. So we used to only serve people 18 and up in housing, and now we can serve 16 and up, which matches what employment has been able to do this whole time. So that's really exciting to be able to serve 17 and 18-year-old or 16 and 17-year-olds in housing. Although it is unique, we want to do more of that. And so always looking for providers who want to serve the youth population. We also have some new reentry work. FCS is unfortunately not directly connected to the reentry work, but it doesn't mean we're not going to try to align and do our best to partner with how we can transition people from out of incarceral settings into the community and into housing. We also got approved for some health-related social needs, which I'm going to go over later. It's a funding bucket that allows for people to transition into housing, as well as some rental assistance for folks who are eligible. So we'll talk about that in a minute. But those are some of the changes. As far as a state, it's much bigger than FCS. There's a lot of different things that are happening, but this is kind of how you show all the different things that came about in the Medicaid Transformation Project 2.0. Do you want to go, Darren? Or you want me to keep going?
Yeah, go ahead. Keep going, please.
So what we want to talk about for a few minutes is just what is FCS. So FCS is a Medicaid benefit. This is something that back in the olden days, as my kids like to say, are something we were just dreaming about, right? Is Medicaid paying for these types of services? Typically, employment and housing were grant funded, and so the fact that CMS is paying for Medicaid benefits is a big deal. So it is providing supportive housing and supported employment services, meaning we're helping people find and maintain housing and employment. We don't do any rent assistance, room and board costs. We're not paying wage enhancements. This is not an entitlement. We're actually still a budgeted program because we're part of a waiver. So until we become a full Medicaid entitlement, we have to be mindful of also the fact that we are still a budgeted program. For eligibility for FCS, the first part, we have two kind of phase things. So the first one is they have to be enrolled in Apple Health. So if you haven't gotten someone enrolled in Medicaid, that would be the first step. We can serve people that are at least 16 years or older for both services now. And then they have to meet a medical necessity, a health need. So whether that's a behavioral health diagnosis, an SUD, or they are diagnosed as having disability that needs support in maintaining housing or independent living. So some of those just living independently, those things that someone might need to be able to continue to live on their own or have support in doing so. So if you meet one of those, whether it's the behavioral health, the SUD, or the complex physical needs, you also have to meet one risk factor. And I'll go over the housing for you, and then I'm going to have Darren go over the employment. So for supportive housing, the first one is chronic homelessness, and we do go by the duration of HUD's definition of chronic homelessness. So that's 12 consecutive months of homelessness or 4 episodes in a 3-year period that equal out to 12 months. What's unique about FCS on the housing side around chronic homelessness is we consider doubling up or couch surfing as homeless. We also allow people to self-attest if they haven't gone through a system. So if someone hasn't stayed in a shelter, hasn't been put through HMIS, and they just need the support and have to attest to their own homelessness duration, then we allow them to do that. We want to screen people in, not screen people out from these programs. Frequent or lengthy stays in institutional settings. So that means 2 times in a 12-month period or more than 90 days stay in those. So that could be skilled nursing, hospitalization, or incarceral settings. So if you have somebody that's going kind of through those systems often or have had to stay a longer term in the last year, they would be eligible. Frequent stays in residential care, same thing, 2 rotations of somebody going through residential care would be eligible in a 12-month period. If you have somebody that's going through in-home caregivers, and this is 3 or more in a 12-month period. So if you have someone that really struggles with their in-home care, which I know as a direct service provider, I had lots of folks that just didn't have a good vibe with their in-home care. struggled. Sometimes it just didn't work out. It wasn't a good match. They would rotate through those folks often. And so if you have somebody that's kind of in that situation, this could be for a lot of people who serve the aging and long-term care population. Those folks would be eligible for supportive housing. And the last one's the PRISM score. And that's a predictive risk intelligence score that kind of predicts how much Medicaid someone might be utilizing. And so if someone has certain diagnoses or are utilizing specialized services, often emergency services like the EDs, they may have a higher PRISM score than the average beneficiary of Medicaid. So 1.5 or higher would make them eligible for supportive housing services. You may not have access to the PRISM score. So one of the things I like to tell agencies as new providers is that's something you would get from primary care or behavioral health orgs. And if not, WellPoint typically checks the PRISM score. If we can't screen someone in through other eligibility criteria, they would look at the PRISM score to see if that's something that maybe would make them eligible for services. So you can get that through different organizations. It's not super easy to get access to PRISM. I just talked through a provider trying to get access recently, and it's actually quite the process. So just know you can get that looked at from other providers you're coordinating care with, or WellPoint will obviously help you try to figure out how we can screen somebody in for a PRISM. Okay, Darren, over to you.
And I think our partners, at HCLA, formerly known as Alta, I think they have that access as well. So you can definitely work with some of the community partners to be able to access some of the information. So on the employment side, again, you only need to align to one of these risk factors. So if somebody is already receiving HEN or ABD, age blind or disabled, they can be eligible for the FCS program. And particularly some of the folks I used to work with, it was really hard for folks maybe to get a job or even maintain employment due to some of the behavioral health or some of the substance use disorders or physical issues, barriers that they're facing. So you can frame it without the services, they are at higher risk at not maintaining employment or maybe even maintaining education engagement or completing their education goals. Or somebody who's really focused in battling the substance use. My dog is really needy, so she's reminding me that she's more important than anything else that I do. So my apologies. That if somebody has some of those substance use disorder history or engagement, outpatient or inpatient, that could be the risk factor as well for services, or if somebody's really facing serious behavioral health issues, or at times co-occurring issues as well, that they really need those intentional case management supports to maintain some stability, or they need that ongoing support. Maybe they're really battling with some of the triggers. Those types of things you can frame in the way that without the services, they won't be successful in maintaining education or support. And this is a really important piece of, the services we're doing that, looking at the reimbursement fee for service rate. So for employment, you can see the rate is $40 a unit. It's every 15 minutes of service with each authorization. 120 units, about 30 hours. So that's about a 6-month operation for that. So I think this is really handy for folks who are just starting out to be able to set up a tracker of those folks that you have who are authorized for FCS services, and also look at the utilization for housing. And as you can see on the housing site, it's a per day per diem, for $145 a day. So this is a great tool to kind of really build up the matrix to see where the utilization is and being able to track because there is the option of the exception to the rule. If you're working with somebody on housing or employment, sometimes it's very intense services and you might be utilizing a lot of hours up front for that engagement. So we want to be able to have that exception to the rule and really show the case of the need for the services and what that outcome is going to be with those services. Particularly, it might be unemployment, that we have some job coaching supports that we need to do. Somebody got a job and we want to do what we can to support them on the job, and it takes additional time. And so those intense services would relate to the person keeping their job during that time. So definitely, it's a great tool to use, but you also have to be able to document the need. Anything to add on the housing side, Kimberly?
No, I just think, one of the things I like to remind folks of, and I think, it's on another slide down the way, is just having a good tracking system to make sure it's showing you, like flagging when you're getting close to running out of authorization units, because we don't want people to have gaps in services. So really making sure that you're putting in place how you can ensure somebody, if they are really working through a lot of units in the beginning, like Darren said, front end sometimes takes more time with somebody than maybe after we get them housed or employed. And sometimes that's not the case, but really tracking how much units are being used early on, so that when you need to do an exception to the rule, you have that in place, and aren't using time that could expend their authorization so that they can get served.
And one nice thing that this shows is you can really provide supportive employment and housing services in conjunction, in with separate service plans and goals, and making sure that the timestamps are separate for the services. But it's a great way to start that conversation of housing or employment working together with folks. So just keeping in mind as you're developing your programs, there's some ways to really the braid funding of the two programs, as long as you have that WellPoint contract that you're providing both separate services. We really
Yeah.
like that open door piece, to the FCS program, that I've worked with people from Department of Vocational Rehab, going on to the FCS website to use the portal to refer somebody into the program. We can encourage family members as well. One of their loved ones might need some of these support services that be crucial, to help them integrate into the community or be part of their community. Or the social service providers, social workers working within hospitals, or even working with folks that who are going to be coming out of an incarceration or a hospitalization, to be able to access these services, to really create that bridge back to the community so they can get some supports. So WellPoint has a great system that it's an online system that you can do the referral. I'll have to pull it up and put the link in the chat a little bit later. But definitely you can provide referrals for housing, for employment, or look at providers who provide both services, so people can take advantage of both services to help them with the stability. So definitely we're going to be diving in to what FCS services are for employment and for housing. We definitely have some separation in services. I'm not an expert on AHAH-RAP, so definitely I'll have Kimberly add a little bit more to that. But we really caution people that we can't mandate that they have to be part of FCS in order to access these Medicaid services. Services are open to all. It's our job as providers, clinician, staff to really work with people and find out what their goals are, and then use these services to really help people achieve their goals. And those are all going to be individual goals that we have. So we really want to caution people not to tie the service into eligibility for the programs. I really encourage folks to take a look at the FCS provider map, as we have folks who are thinking about providing services. There's some providers areas that are very saturated with services, and then we also have folks, parts of the state, who don't have a lot of choice in providers. So definitely we encourage folks to take a look at that. We also encourage folks to think about collateral services, and this is a service that can be very unique to FCS, that at times when you're engaging with employers, you may not always have that participant with you, but you always have to think about what's that medical necessity I'm helping the person, state. Darren's not able to attend the meeting today, so I'm going out in the community on their behalf. Due to this limitation, I'm going to engage an employer and find out what the essential work functions are, find out what the interview process is, find out what essential skills that the employer is looking for, all those type of things, so we can tie it back to that medical necessity on why we're advocating in the community for employers. And this is also true for landlords or visiting communities to kind of see what the comfort level is that somebody might be choosing, or hopefully go in and see some units as well, because that could be very revealing once you're in a unit to kind of see if it meets the person's needs. And there are times where there might be the need to have separate service providers, and WellPoint can work with that in terms of providing housing services from one vendor and supported employment services from a different provider. Anything to add on the GOSH or anything else?
Yeah, I'll talk a little bit about the difference between some of these other housing supports that we have out in our communities. So HEN initially came from being a short-term rental assistance program to now what HEN looks like is very different. People are allowed to be on there much longer term. The difference, though, is we don't have rental assistance. HEN is mostly a rental assistance and necessity support. However, because of the lack of funding and the ability to be able to serve the need, not everyone gets access to HEN funding. And actually, it's a very small percentage who actually receive the rent assistance, right? So some communities have folks on long-term wait lists for HEN, even though they're been deemed eligible because of just funding and need. We sometimes have folks sitting on the HEN wait list for a long time. HEN is, some programs do provide case management, and you probably will see a little bit more through the HEN program. They just did a research study around HEN and determined what FCS has known for a long time is that with shorter or smaller caseloads and better case management or more case management, someone will have successful outcomes through that support. And so I think HEN is looking at how can we balance the money for rent assistance versus the need for that case management to support somebody as they're transitioning into housing. So that's HEN. We are partners with Commerce. We have done some really great programs around HEN. And so although it has had a challenge just because of the need, it doesn't mean we don't want to get people on those lists if they get access to that. And a lot of times that goes through that coordinated entry system. FCS does not go through coordinated entry. We also have programs like GOSH, that is for the aging and long-term care population. And so that's through the HICLA, DSHS folks. And so a lot of times this is serving a different population than FCS. GOSH also has some resources that we don't have for FCS, but are for that specific population, either exiting the hospital or at risk of being in the hospital. And so that is a supportive housing program. It's the governor's opportunity for supportive housing. There's some great information about GOSH, and some of you might even be GOSH providers. So, and then we also have like HARPs, housing and recovery services through peer services. So we want to make sure that folks get that access. That again is through HCA, and HARPs would be serving folks again who are trying to exit hospitals or preventing them from going into or at risk of being hospitalized. And so we want to keep people in the community being served through supportive housing. HARPS does have funding in specific counties, and sometimes the provider does both the subsidy and the case management, and sometimes it's separate. So if you don't know who your HARP provider is, it might be interesting to find out. It's a great partnership because a lot of times what we find is when folks first go into HARPs, you don't have to be eligible for Medicaid for HARPs at all, but there are folks that are eligible for Medicaid. So they might enter into HARPs initially as they exit inpatient, but could easily be transitioned over to FCS. So that partnership with the HARPS program could be a good referral pathway to make sure people are getting served long-term. Again, HARPS isn't designed to be long-term unless they're non-Medicaid. So if they are Medicaid eligible, then transitioning them over to FCS would help them have that longer-term care so that HARPS can serve more folks through that kind of shorter-term support. Oh, the no-no list. There are some things we really want to talk about around things that really aren't great for a Medicaid program and things we want you to be just mindful of. So We have been pretty competitive in FCS, which sometimes surprises me, but I did housing, so I get it. What we don't want to see is providers trying to take each other's participants. There's plenty of need out there. There's a way to look to see if someone has been enrolled elsewhere, and it is participant choice whether they get services from you or somebody else. That's a Medicaid rule that somebody has choice in provider. So there should never be a requirement in a program that they have to receive services from you, whether you're providing housing or not. So make sure you're giving people choice and that you're documenting that. And there shouldn't be any, I hate the word poaching, but poaching from other providers, because there's plenty of folks out there to be served. And I think working together as opposed to trying to compete always provides better services to our communities. You should always be doing an assessment for FCS with a participant present. They are the ones that should be being assessed. Questions that shouldn't be happening over the phone. That in-person interaction, especially when you're first enrolling somebody into a program, is really crucial in just getting to know somebody, building that trust. And so really helping them understand that they have a choice in whether they enroll in this program. I think that goes back to choice again. We don't want folks thinking that they're required to enroll in something if they're not interested in those services, because then they feel like they're obligated when they don't really want that support. So we want to make sure we're talking about what this assessment's for, what is the program, and ensuring that they understand what they're signing up for. Historically, we've had some times when somebody didn't know they were enrolled in the program because it was just an automatic enrollment. So just making sure we have that conversation and document it. Billing, housing, and employment, like Darren said earlier, it should be separate services. So we should be time stamping how much time we're spending with someone. Our evidence-based practices really say that we should be having a separate person providing housing versus the who is providing supported employment. And the reason really behind that is we want to make sure that someone's being able to address whatever supports they want at the same time, and nothing is taking precedence because it's a crisis. And as housing exists, a lot of times when someone is unhoused, that feels like a crisis, and we want to address it right away. But there are folks that think employment is just as important, and it is. And so there are times when we want to make sure that if we want employment first, we do employment first. If they want to do housing, they do housing. If they want to do both, we have separate people really committed to the time to support that person on that specific need or goals. So we want to make sure that people are thinking about that the case notes reflect that. We should never see an overlap. If someone really needs some employment support, we should refer them to an employment specialist, whether it's your agency or somebody else. That's part of what we do in housing, and vice versa with employment. If they're working with somebody and find that there's a housing need, if you're not providing the housing, instead of incorporating it, can we refer them to an agency that really focuses on those needs? This is Medicaid, and so making sure that we're very accurate about the time that we're spending with someone, making sure you're doing timestamps, that you're documenting what you're doing with somebody to be very clear, because we do sometimes see in Medicaid that people inflate time. And employment billing is a little bit different than housing. So sometimes it's, trying to determine which way you go around how you bill. And Darren talked about the rates. So 15-minute increments for employment, 145 per diem for housing, but we never inflate that time. We need to be very clear about how much time we've spent with somebody. As long as it's 15 minutes or more, we can bill for these services. We are a community-based service, so FCS is really designed to be intensive case management out in the community, meaning we are out there walking alongside them, meeting employers, meeting landlords, looking at opportunities. What does a job look like? What does a house in that community look like? Do I need to go to Social Security? Do I need to go to DSHS? We should be out there navigating that space with them in the community, meeting people where they're at. If you're a housing specialist, I hope you're doing home visits with folks. That's where we really see some stuff and really get to connect with folks. If you're an employment specialist, are we really helping somebody think about the types of employment that work for them? Not that it's just a job, but that it's a good fit, like really doing that discovery to make sure. And some of that's going out in the community and just shadowing jobs, looking at what's out there. Maybe it's just Darren taking somebody out to a space just to see what it looks like to be an employee there, right? And what does that culture look like? So we have to do a lot of that in the community. These are really supposed to be a wraparound service. This was never intended to be a standalone program. So we really want to make sure we're doing the coordination of care, working on services that maybe might be outside of our book of business. And so you should be doing the full scope of FCS if you're providing FCS services, meaning you're doing the pre-tenancy, pre-employment stuff, and then that follow-along support, whether they're housed or employed. Are we continuing to serve them? Whether our agency provides other services, we should be continuing to do that as a program. So if you're doing FCS, we really want to make sure you can do the full scope of services and provide that, not only pre and post work that we do with folks. Both of our evidence-based practices look at caseload. So we'll talk about this in a minute. I know we're both going to go over our principles, but really lower caseloads allow us to have the time we need to do intensive case management, which is what this program was designed to do, and still be able to do all the coordination of care and the wraparound and the documentation you're required to do as a Medicaid program. So all those other duties as assigned as we're serving people, that's part of it. And so if we have too big of caseloads, we're getting folks who don't have time to do those things, or maybe people aren't getting served as well. There's burnout, there's all sorts of things that can come with high caseload. So the best you can do to get closer to those smaller caseloads, the better outcomes we'll get with our folks and our staff, really. And then, like I mentioned already, one person providing supportive housing and a separate person providing supported employment. We do have programs that have somebody that does the same, but they have to be really clear about what they're doing with that person in that time. And really our evidence-based practice says it should be a separate individual so we can get better outcomes around both housing and employment. So it sometimes can get blurry when you're talking with someone about housing and then employment comes up. We have to really, it comes, they're hand in hand. That's why they're hand in hand, is because it comes up all the time, right? So somebody might be trying to get employed, but doesn't have a place to lay their head at night. So how does an employment specialist navigate working on the housing piece? And vice versa. Housing folks historically have done a lot of employment work when supported employment wasn't necessarily in their community. So we want to make sure we're being very intentional about how we serve folks in FCS. I'll turn it over to you, Darren. Oh, you're muted.
Yeah, I'm muted because when I go to the HCA YouTube channel, sometimes it pops up with audio, and I try to avoid that, but I forgot. So thank you for Kimberly keeping on track. But I just want to check in. I know there's been a lot of great questions in the chat and the QA. Hopefully, some of the information is helpful that we're sharing. But I just wanted to kind of take a break before we jump into something new. If you're getting the information that you're looking for, I know Kimberly, somebody asked some specific information, I think, about the AHAH-RAP's program. So I don't know if there's some extra stuff that we definitely can send out some additional information and some links as well. But I just wanted to kind of pause to see if we're meeting the needs of folks who are doing a great job of putting stuff in the chat and the QA.
I'm just trying to look at questions really quick. You'll get a recording as soon as this is done. It'll send you out some emails about follow-up and recordings. So just want people to know you will get this to watch again. And we also have many of this version in our FCS YouTube channel. So there's lots of recordings you can access through past trainings. I just saw a question about folks that are already enrolled with somebody else. So if you have access to provider one, you can go in and pull up their number and you will be able to see if they're already enrolled in FCS. It'll specifically say FCS. It will not tell you what provider, however. So if you are trying to get someone enrolled, maybe they didn't realize they were an FCS provider or enrolled in FCS, you can call up WellPoint and ask questions. You may need an ROI, but that's the best way, is to have access to provider one and be checking it regularly. And it'll tell you if somebody's already enrolled. And then we can kind of investigate who they're enrolled with. Do they want to change providers, or do they want to stay with their provider they're currently enrolled with?
Sorry, I'm just putting an extra link in the chat for our YouTube channel.
Thank you.
So we do talk a lot about evidence-based practices. Oh, looks like we got some few more folks jumping in. Cool. I'm not familiar with DSNP. Is that something you're familiar with, Kimberly, in the chat?
I'm not sure.
Did you want to unmute Rhea and share a little bit more about that?
Yes, so that plan.
We can barely hear you.
Sorry, is that better?
Yeah,
Yes.
that's better. Thank you.
Thank you. So this dual special needs plan involves Medicare and Medicaid combined.
Yeah, I was just talking to a provider about this because this is a challenge. A lot of our folks are on the track for Social Security or have Social Security or disability. And with dual enrollment, it does create a challenge for FCS because you have to be currently enrolled in Medicaid to receive or to be able to be billed for these services. So if somebody has dual enrollment, when they're in that spend down time where they're Medicaid or Medicare, they wouldn't be eligible for FCS services. So if you were trying to bill for time you spent with them during that spend down time, you would be denied. So that is the challenge with that population. We are trying to figure out how to address that because there will be folks that kind of go in and out of eligibility because of the insurance they're on. So that is a challenge now. So if you have a population that's mostly dually enrolled, it would be difficult to be able to continue to bill for them through their 6 month off until they have that spend down and they're back in Medicaid. You would just get denied all of that encounters that you.
So let me rephrase what you just said. So basically, anyone with the spend down category would not qualify then, but someone not on that or requirement would qualify then?
They, as long as they're in, well, so as long as they're in Medicaid and they meet our RAC codes, we do have certain codes that are not eligible. And so I can send out a list of the eligible RAC codes as well. We have a master list.
Okay, that'd be helpful. Yeah.
And that, yeah, I
Thank
was
you.
gonna say that might be helpful just so you know, if they're enrolled in the wrong program for this program, it would, yeah, you wouldn't want to put the effort into trying to get them eligible because it would be. Thank you, Darren. You're on the spot. Look at that.
Hopefully that's the most updated master list. So
Yeah. We still evolve as an agent or as a program, and so sometimes we learn that we need other RAC codes or things or other, so we're working on that. But yes, this should be the most recent one, and just have that as a kind of a resource for you as you're thinking about either doing this service or if you're already contracted to provide FCS. It's a great tool just to make sure that you're thinking about who is truly eligible for FCS. Okay, I see Ben. Is it Ben or Benjamin? I see your hand up.
Oh, I'm only Benjamin if I'm in trouble.
Okay, fair.
Yeah.
You can only be Kimberly.
I was just going to say, like in the past, just to make it simple, if our clients had Medicare as primary and Medicaid as secondary, we always got denied. But if they had Medicaid as primary, then sometimes we'd be able to get them approved. And for anyone who is Medicare primary, we just stopped trying to apply.
All right, thanks, Ben. I appreciate that. That's very helpful. It's true that I think it's really, is Medicaid their primary, and are they going to be continuously enrolled during that eligibility or during the authorization? They're 6 month offs. And so as long as they get approved, but you have to still look, that's why we say provider one's really important. You should be checking provider one all the time. Someone can go into jail for 2 days and it could affect their whole month of eligibility because of the Medicaid pause that happens when someone gets incarcerated. So those are just things that to be aware of for providing these services in the population that you may be serving. I saw someone else's hand up, then it went down. Did we answer your question? I can't recall.
Was that Cynthia?
Cynthia?
I did see somebody's hand go up too.
That was me.
Oh, okay.
Can you hear me?
Yep.
Yes.
Can you guys hear me? Oh, I just wondered, where do you send these people that don't qualify for this? Is there that might be something else, but yeah, that's an issue.
Yeah, you're right. I mean, the eligibility is pretty specific, and sometimes it is hard to find other services for folks. HARPS is an eligible program that's non-Medicaid, but it has a very kind of intentional population it's trying to serve. It doesn't mean they wouldn't necessarily be eligible. So I can send out a list of different supportive housing programs. We also at HCA have what's called the Housing First or Low Barrier Housing Program that's very FCS-like, but you're not required to be Medicaid eligible. So there is some other additional programming that could support folks if they're not FCS eligible. So I'll try to send out as much resources as I can in our follow-up so that you have some matrices and things to see what is available in our state.
Thank you. I appreciate that.
Absolutely. All right, you want to go into evidence-based practice? Did we already cover this? I feel like that wasn't worked out there or not.
I don't think so. I think it's just been kind of hanging up a while we've been answering some questions. So we talk a lot about what evidence-based practice is, and definitely it's based on research for the supportive employment model. That research started back in the 80s at Dartmouth University, where they were looking at current models for supportive employment and looking at some of those threads and learn best practices to really support people. And over time, it became more refined, where I think they have 26 different studies just done in the US and now even worldwide, because we definitely have some international partners as well. So in some of these research has been done over different populations with some of the same outcomes, and saying if you use our models, we're going to have higher outcomes in people attaining employment, education, and securing safe and affordable housing. So it's really using the different principles and dimensions that we're going to be talking about a little bit later, and it creates a great roadmap for services. So definitely I encourage people to take a look at those and then take some time to adapt them all. Definitely for employment, there's 25 different principles. I wouldn't want you to attain or try to do those all at once. It's definitely takes some time. Doesn't have to be linear, but it does take that planning to do some implemental. And it's really taken some of these principles and using our FCS community to adapt to the principles and being creative, being out in the community. I think that's the primary one, and really validating people's goals and desires to help them attain, to get that buy-in in the job search process or the housing process, so that we're aligned in the goals. I've always found when we're build that close relationship with somebody and we're working towards goals, when they're able to get employment, they stay longer because they have a lot invested in the process. Even though there's sometimes people can start a job and say that's not for me, or learn about neighbors or noise or different environmental cues, in housing, that people can change their mind. But that's an important part of our models too, that when people change their minds, we can provide those additional supports to find that successful placement for them to be successful in the community. That's what we want through our models. Next slide. So we talk a little bit about fidelity, and we're really talking about some of the best practice that you can use, which is quality assurance and quality of improvement. Both of our programs really focus on that. We really look at some operational things. We look at integration across programs and with leadership and executive team as well, so that we get support in our program. For employment, I think it really is a culture change, adding IPS to a program or starting an IPS program within an existing organization. It may not be easy, especially if you look at the manual, look at all the fidelity scale. There's a lot of different pieces, but you can be very intentional and strategic about how you implement things so that you do over time, adhere to the best practices and adhere to the anchors within the program to achieve higher fidelity. And this is also something that gets looked at. I always encourage teams and programs to do a self-assessment to see where you're at with the fidelity scale, the dimensions for housing, and revisit to kind of see how you're doing and adhering to the model. Kimberly and I are also available to come out and do fidelity reviews. It's a great learning process to see how the program is being implemented, what success is, and an action plan to kind of work on some different dimensions and principles to have a higher fidelity program. But I think the core is that we really want to work with programs using the evidence-based practices to really start the program and adhere to those different anchors so that you have a successful program meeting people's needs to be employed and housed in the community. Next slide. You want to take this one, Kimberly?
Yeah, and you're going to hear fidelity from Darren and I a bunch. So just be aware that that's a key word. We're really wanting to focus on quality assurance and making sure we're consistently providing quality services across the state. And actually, in our pilot projects, as I mentioned earlier, we started to kind of explore evidence-based practice in some of our programming. And so in 2013, we were legislatively mandated to provide these using evidence-based practice or promising practices. And so that's where we came up with, we've seen these pilot projects do great work by utilizing these evidence-based, whether it's IPS for employment or PSH through SAMHSA. We were getting the outcomes that we desired for folks because they really gave us a recipe or a guidebook on how to provide good services and make sure we're thinking about those dimensions. As Darren said, employment has a few more than housing, but they really align with when you look at what we're going to talk about here with the 7 principles of supportive housing and the 8 kind of core principles of IPS, you'll see that they really do kind of mimic each other in the way of what we're trying to do with folks and serving them well in our communities. So I think it's IPS first. So that was a quick switch, but there you go, Darren.
Okay, well, that's always good timing. So as I mentioned, this is a non-linear process. I think programs need to be flexible. This is a cultural change for an organization. I implemented IPS in my organization back in 2008. Before that, we had a different type of supported employment program, not as effective as the IPS program that it merged into and changed. But it takes time. It takes a lot of communication. And sometimes the supervisor or the manager is the real champion to be able to implement the changes and change that culture and that belief that people with some of the challenges that we've talked about, some of the barriers that people face, can be successful in employment and education. So definitely building on that support, culture change, and lowering barriers for services. Kimberly talked about Darren loves tracking. Love spreadsheets because it's a necessity to know where you've been, where you are, and where you want to go. Plus, it's a great tool to share with your teammates, share with leadership program, demonstrate the changes and the changes of people's lives that we work with, and really focus about being out in the community to provide these unique, intentional, individualized services. Okay, next slide. So here's some of the 8 principles that we're going to talk to and share some information about. Definitely there's 25, but these are the core pieces that make up the IPS system, that definitely focusing on competitive employment, integration with team members. And again, zero exclusion for me is really changing the culture and looking at low barriers. It really starts at the front door, how people are greeted, what kind of information is available to them, for them to learn about the different programs. Is there empowering messages available, for that? And how we work with folks and learn what their passion is, what their desire is, what their sense of purpose is, so we can work hand in hand with them to be successful. Benefit planning, when somebody has some earned income, things can change in their federal or state benefits. So we want our FCS providers to understand some financial wellness, understand work incentives through the Social Security system, and educate people on potential changes that will be coming up. And also intentional in terms of if somebody is sharing their goals with us, how quickly are we adapting to be able to work in the community to make those goals a reality? Is it 30 days? high fidelity? Is it 60 days? Is it 90 days? Is it 270 days that we're working with people prior to engaging in that job search process? So we really want to honor the individual, validate their goals, and start that process to engage in the community about that. Data tracking, there's some specifics about supported employment and IPS that folks need to be aware of. There's a little bit more data collecting and data tracking to see where folks are at. When we talk about time limited supports, we talk about certain things in terms of there's some certain benchmarks we look for within the IPS that we're having connections with people before they start work, after they start work, intentional for that first month, and then kind of see if we can pull back or do we need to provide more intensive services for that. Plus, time and limited supports is really helpful for our partners at Division of Oak Rehab because we can provide those ongoing supportive employment supports after their VR plan case successful closure. We could still use those FCS supports to help them maintain employment and or support them in their educational goals as well. Next slide, Kimberly. Yay. It takes a while to love the principles. I can say starting off in 2008, didn't really love them, but you get to as you develop your programming and work with your team to be able to do that. I'm just going to take a minute and kind of look at the chat to see if there's some things that I missed. Yeah, Annette, I can sympathize with, there's so many changes out on the horizon. It's funding is always a question I had, even when I was a provider managing a program, to today, and really trying to work with folks to braid their funding sources, because I think FCS is a great way to blend and support current resources, because in this day and age, I think you have to be on top of your game for looking at funding, contracting opportunities to support the programs. Do you want to go ahead and advance the next slide, Kimberly? So there's also a few other things we look at with IPS principles. We really look at small caseloads, 20 or fewer for high fidelity. But I know when I managed the program, I couldn't make budget at 20. So my goal was 25. And that's okay. You can make those choices that are unique to the program because one, it's always important to keep your doors open to provide these services. But we still want to make sure that we're not overloading staff with too many. I've also worked in programs where funding went away and caseloads went sky high, and you just can't provide those individualized employer contacts, focusing on job development. It's more crisis management, case management type duties, and you lose that specialization that we provide. I've talked about Division of Oak Rehab a couple of times. It's, you know, a great resource for folks. Definitely there's an application process to see if folks are eligible, when it's eligible. There are some additional resources that a team at VR can provide to help people on their employment or educational journey. I encourage folks to go to the website and kind of see the services they provide and just some awareness that they're currently in an order selection. So even if somebody's eligible, they may be placed on a wait list before services can be provided. But that's a great way to use FCS services as well. If somebody's on that wait list, maybe there's some things we could start doing now through the FCS program, you know, as we look for that wait list to open up for DVR. We also want employment specialists to really focus on employment services. I know that sounds kind of simple when we say it, but I know a lot of providers are starting up programs and people may have 2 or 3 or 4 different responsibilities and people are just pulled in different ways, can be hard. And I know particularly with FCS, I've seen people blended employment and housing positions. I understand it as you get started. It's a tool, but we really encourage for people to be specialists on both sides, that they have that specialized caseload for employment and for housing. So definitely that's a recommendation we see, and definitely recommendations I provide, is really keeping those positions separate and making them unique to provide the services. We also want that relationship to develop with the participant. So when they come in, get an intake at the organization, that then that employment specialist is doing the career profile, looking at their history, getting to know the person, then starting that employer engagement process, job retention supports, whatever that looks like, it's all done by the same employment specialist. Part of this process about getting to know someone is getting to see how they view themselves and how they view the agency you're working with. We have a process called disclosure where we're trying to see what the person's perspective is as we start that job development process. Are they comfortable with me going out with my behavioral health business card, going out and talking to employers? Are they guarded and more reserved and maybe need to get to know the employment specialist in the process before they're comfortable sharing some more information? So it's always good to go through that pros and cons to kind of see where they're at, how they see themselves in the job development process. Maybe they want to see them take the lead and engage with employers and have that coaching support. Or maybe they want to go hand in hand and work together with employment specialists out in the community, visiting employers in schools. So being sensitive to their needs and how they see that process, and for the employment specialists to be comfortable. What information potentially could be shared? You know, what safeguards do you have in place to meet the person's needs? I've talked a little bit about community time, definitely for high fidelity. IPS looks at 65% of its staff's times in the community, visiting employers, schools, maybe it's DSHS, Social Security, DVR, what that looks like for the person's caseload. But these services are designed to be in the community and support folks in the community. And we really want to see a high level of engagement for that. I always encourage folks to start at 30% and then start building up goals as your staff become more acclimated to be autonomous out and independent out in the community. From time to time, people stop engagement, and it's up to us as a program to kind of see what else is going on. Are there some health issues? Are there some trauma issues going on? What that looks like, and try to engage people in different ways, or engage through different network supports too. So we want to be sensitive that just because people don't show up, that we're going to go ahead and close their case and not engage. We really want to make sure we're making those extra steps to see where folks are at. Sometimes things are going well and people say, Darren, I don't need you in my life or in my business anymore, and I'm ready to, take the lead. But, I'll keep your phone handy so I can give you a call if needed. That's always great to hear that people are, being independent in the community and being in charge of their goals, and particularly in work and education. But we always want to encourage them that we're always here as an anchor, that they can relate back to if things change and they need extra support. Bethany, you has clarified that, yeah, this is a full-time staff for the caseload of 20 or fewer. Yeah, per FTE. That's high alignment to the fidelity model. I've worked with programs. My program I operated, I couldn't do that. So I was a little out of fidelity, but it worked for my team and for my program for that. Next slide.
Something to remember, I'm sorry, Darren, I'm just going to piggyback on that, is that we know this is like winning that fidelity if you meet these spaces, but we also know that we work with a lot of non-traditional providers, and that you have budget needs and all the things that come into play with nonprofit. So this is where we hope you can get to. But there are times when, like Darren said, his program couldn't have those low caseloads because of budgeting issues. They had to meet revenue, right? So yes, this is where we want you to be. And we also understand that you might not automatically get there. It might take some time. Maybe you never get there. But with fidelity, the great thing about fidelity is it's a recipe to get to that best optimum services. However, we also know it ebbs and flows depending on who you're serving, what county you're in, what are your program needs. So we also understand that sometimes it's an evolving thing and it can change. So whether you're there now or you can get there later, or maybe you don't get quite there, it might be just something your agency, I always say, do what you have the most control over. So start there. When you're talking about fidelity with Darren and I, we're going to say, what do you have the most power over? Start there. That's the low hanging fruit. So if you have to do something different to get to that fidelity, it might take some time, and we're not going to expect you at your baseline to be at fidelity, right? That's why we're here. And so there may be teams that never get to 20 or less in employment caseload, but as you're trying to work to that or thinking about how you can get closer to that, that's where Darren comes into play. And the housing thing will be the same, only our caseloads are even smaller. So I know people go, so.
Yeah, thanks for that, Kimberly. I just want to shout out to Bethany with DVR. I remember working last order selection and caseloads just climbed. So, thank you for the work that you do and the passion and support that you provide people. I'm sure you were pulled in many, many ways, being able to deal with 119 on your caseload. I can't imagine that, but I know that's got to be really hard for that. But yeah, we really want to try to focus on individual needs, and things can change. It's flexible. The model, not so flexible, but Kimberly and I, we have that experience of working in the community, operating programs and supporting programs. We know when the rubber hits the road. It can be always different in different situations, but I think there's other principles within the evidence-based practice that are so important, like person-centered planning, and some other things that we'll talk about. So it looks like we're going to jump into FCS services. Any questions about some of the IPS things that I mentioned? Yeah, sounds like there's a community out there who know the hard work that you guys are doing out there. So that's great to see.
Yeah.
Well, thank you, Annette. Definitely, I have a day off next week, so I am planning for some self-care that day.
I think anyone that's worked in direct service knows that you are probably, it's very rare to get into those kind of places where you can keep your caseloads that small, because in the business we're in, we want to serve everybody that needs support, right? So it's hard to turn people away. And most agencies choose not to have a wait list and choose to serve whoever comes through their door. And in that, they also end up with higher caseloads, but they're willing to take that. So even when we do fidelity reviews, whether it's employment or housing, we understand that you might know you're going to score lower on this, and you're good with that because you've chosen to take everyone through the door, and that's fine. We want people served. And also, you may get higher scores in some other area by providing choice or zero exclusion or whatever that might look like. So don't be afraid to make decisions based on your agency. Just know that when you're talking to Darren and I, we're going to always give you the principles, always explain how to get closer to it. And as an agency, you get to choose whether you can make those pivots or not, right? And so we have those conversations. We can walk through the training of it. We can talk through what that looks like. But it doesn't mean you can do everything that we're asking you to do, because you maybe don't have authority over the entire provision of what programming looks like. So we just want to help you get as close as you can to that.
And sometimes we do pivot from Darren's IPS manual mannerisms to FCS, and it's different when you got to roll up your sleeves and do that. So so we're looking at some of those pre-employment services and really focus on this is that relationship development time, which is a billable service, because we're getting to know the goals. We're getting to know a little bit about some strengths and abilities, and maybe some of the barriers, and maybe some of the trauma that's happened in the past. I always wanted to be sensitive not to put somebody through a process of trauma or repeating things that may not have worked in the past. So it's a great time to really learn from the person, and it takes time. People were usually not forthcoming with all the challenges that they faced, maybe a little guarded. So it takes time, for that person to feel a little bit more comfortable as somebody new who's going to be asking things about strengths, abilities, your finances, transportation, a lot of different things. So it definitely takes time, but we really want to have that person-centered, and in the service planning and treatment planning and setting up goals, that the person is incorporating information that we use for some of the short-term and long-term goals as well. We really want to focus on individualized job development. We're just not going out there hitting all the employers in a strip mall and say, wow, I got my contacts for this weekend. Yeah. What are those positions and how do they align to the goals that the person initially shared about? Do they tie in? You know, that's about fidelity, that people say they want something. How are we providing and aligning services for that? Now, sometimes I've worked with people, they want to be an automotive mechanic. Maybe they have to go through a training program to get certified, but they need a survival job now. That's why it's great to have that service plan, short-term, long-term goals, and have that job search plan that really kind of dictates what employers we're going to go see, who's taking some responsibility to make the connections and balance out the workload for folks. So I think there's some important tools that people can use to really accentuate how it's being individualized. Within FCS, if you have a great relationship with an employee, you can talk about job carving, maybe taking a part-time or full-time job and making it smaller to match the skills and needs of the person. So customized employment job carving, in my experience, is that you need a really great relationship with that employer so that you can go in and, you know, provide those additional supports so that that customer, that participant is successful on the job. And again, benefits education. Kimberly and I are both passionate about this, but we really want to make sure when people have earned income that they know what's going to happen. And sometimes it's the person we have to educate, sometimes it's a family, sometimes it's a significant other, and sometimes we have to repeat things. I've had people return to work even after educating them about how they are required to report to Social Security. But they said, Darren, you know, I'm just not going to do that. And then I always talk about overpayments and some of the pitfalls that that might entail, large paybacks. People still ignore some of the advice, but I need to be able to reflect that, do that reality check with phones and document that we're doing that good job. There's a lot of resources. Definitely encourage people, you know, to check out the Pathways to Employment site. I have a lot of information on benefit education there, or just reach out if you need a consult and some resources. Well, I'm always available for that. We've seen some confusion about transportation, that if somebody leaves their agency to go to a job site to do job development, is that a covered medical service? You know, no. But if you have the person with you and you're talking about maybe breathing exercises that decrease somebody's anxiety, maybe using a resume to help with their cognitive performance at an interview, it's that kind of windshield FaceTime that we have with our participants so we can craft that medical need for the support we're providing somebody in the community, or minimize some of the barriers, helping them get to an interview, you know, 15 minutes early, whatever that looks like, we can craft that. But the person needs to be with you, and that it doesn't count if you go to somebody's home to pick them up and you have to wait 30 minutes in the car before they come out. That's not clinical billable time. You have to have that person with you in the vehicle for that joint windshield time. And again, you know, building that relationship with folks, definitely IPS for employment and for education. There's a lot of times where all these principles, you know, tie in to the supported education goals as well. We really want to see how we're decreasing some of the barriers so people can be successful and engage in the community. And collaborate within your team, within natural supports, or maybe some identified providers in the community that really help people as a team to support somebody on their employment journey. Next slide. So FCS also has the supports for somebody when somebody's successful, they're going to school or they have a job. We want to provide those ongoing supports, you know, to match the person's need, to make sure things are working out. I've worked with people that they get a job, co-workers, interpersonal skills can be a challenge. The supervisor leaves. Maybe we need to come in and talk to the supervisor to kind of share some strategies that have worked in the past. Sometimes businesses get sold. So, you know, there can be some traumatic things or traumatic changes that happen. And we just want to have that relationship and be that support for the person as they face different changes out there. For job accommodations, I've used that in terms of negotiating when somebody starts or ends a shift just because of transportation. Some folks are sensitive about their federal benefits going down and they don't want it to go to zero. So maybe we advocate for a smaller work shift so that they can maintain their Social Security benefits. Or maybe there's some assistive technology, and this is really where the expertise for the Division of Rehab folks come in, because they have some expertise in the medical field to link different technology to help even decrease barriers even more. They were very instrumental in helping people stand for long hours, or getting eyeglasses that they needed for the position. So there's an array of different benefits that you can check with those who are eligible for VR services. Sometimes it's going into a job site and kind of seeing how the job site works, and maybe there's some efficiencies we can add to help somebody's productivity, to kind of help them in that first 90 days of job placement. Or maybe we go in and work side by side, not doing the job, but helping the person master some skills, or just acclimating to a new work environment can help them with their productivity on the job. In asset development, I think on employment and housing, there's some financial planning that we can do. Maybe we can talk to people about ABLE accounts. We can talk to people about budgeting. There's some different things we can do to kind of help them with their financial goals. And again, just being able to be available for those follow-along supports, however that meets the needs for our job placement or educational participants. Next slide. Okay, I hand it over to you then, Kimberly.
You'd think we'd know these slides really well by this time, but I keep...
Yeah, because we just did it like somebody else shared. I just saw you guys like a week ago. It's just like, yeah.
There's some really great questions in the chat. I just want to make sure, hopefully we've addressed everything that I've caught. I'm going through the Q&A and the chat. Sometimes having both makes it harder to follow both, so I apologize. Maybe Darren can kind of scroll through and see if there's additional questions. But before we move into housing, just curious, are there any questions for Darren around what he just went over? Because I feel like we're going to maybe run out of time. So I want to make sure we're answering questions.
Maybe.
Okay, so if you do, throw it in the chat or in the Q&A. We'll keep following it. It's just hard to navigate both sometimes. So we're learning Teams a little differently than we used to use it. So have some grades for us, please. Okay, I'm going to go over PSH with you all. Like talking about what is permanent supportive housing. So what FCS was really designed to do was help people move into independent living, right? Move into that space where they could have housing, employment, and really empower themselves and move forward in their lives. So we've had a lot of conversation in Washington State about our definition of permanent supportive housing, and we have come to a conclusion. So this is our, evidence-based model. And when I think of PSH, I think of the SAMHSA's evidence-based model. Some people, when they hear PSH, are thinking about the project-based housing that exists in our community. Both are true, but the PSH evidence-based practice was really designed around behavioral health providers initially, and we use it in all of our agencies programming. HARPS uses it as well. But not everyone's going to get to exactly perfect fidelity. In fact, if you ask Darren or I, perfect scores don't really happen because you're providing choice. And when you have people's choices in mind, you may not get to that perfect score, but you can get as close as you can, right? So the PSH project-based housing actually has a harder time sometimes meeting this evidence-based practice, only because there are policies and things in place that make it a little bit harder to get there. It doesn't mean it can't happen, and it does. We have lots of evidence of that, but it does mean that we have to pivot sometimes in ways that make it sometimes challenging to really do the whole thing and get as close as we can. So that's where Darren and I come in again and help you get as close as you can to that fidelity model. So this is all about people living in a permanent space where they're signing a lease in their own name. There isn't a bunch of rules around it. It's really just they are the leaser to this housing, just like any one of us would live in, with support services in place as well. So when you're looking at a project-based housing, it's the services and the housing that come together. And sometimes, and I hate to say this, the three legs of the stool, when we talk about our Apple Health and Homes program, really brings together the units the services, and the funding for that housing. So these are the 7 principles of supportive housing, and this probably won't be the only time you hear me talk about this, but we'll just go over them briefly. So choice of housing is really about making sure folks have real choice in where they live, who they live with, what that looks like. So it's not really just about seeing what someone needs in their housing, but really asking them what they want in their housing. We know, and just like Darren said, when you have somebody that feels like they belong in their community, they're more likely to stay and be more successful. The same goes with housing. If they can feel like they really belong as part of that community, we will see them stay longer in that unit and be more successful in that unit because they have connections, they've networked, they maybe have spaces where they work or volunteer, whatever that might look like. And so we really want folks to feel like they belong. And so we want to give them choice in who and what that looks like, who with and what that looks like. Separation of housing and services. This is really important in the way that a supportive housing specialist doing FCS services or any supportive housing services should really be the support role. We should never have responsibility that requires us to provide an eviction or give a notice or do some of that landlord housing management duties. You're their support. So a participant really should be able to trust you in being able to say, I didn't do well this month. Maybe they spent their money on something that they don't want to be really transparent about, or maybe they tell you, and our job is to say, hey, I understand you can't pay your rent this month, but let's see how we can get you some rent money or some support so that you can maintain your housing. So there should never be a dual role in what you're doing as a housing specialist. There should be a landlord, housing manager duties, and then you as a support. We're going to work with our landlords. We're going to work with our housing specialists. We're going to work with property managers, but we're going to support our participant always. And so our job is to not have anything holding housing over a participant's head. So there should be no, like, you have to comply with this program to stay housed. Those things should never happen. Decent, safe, and affordable housing. The first one is decent. Most of us are very familiar in the housing world around the housing quality standard inspection that HUD does, or the housing habitability standard inspection that Commerce asks for. Those are things that are important, not just because we expect people to live in units that pass, but we want to have the conversation with them about what happens if they move into somewhere that doesn't pass an inspection. So for FCS, you don't have to be certified to do an inspection, but we would hope you're having that walkthrough and talking to the participant about what that unit looks like. Maybe it doesn't meet HQS today, and they want to live there really badly, but they also have maybe a couple months left on the wait list for a voucher. And so having that kind of informed discussion about, if you were to move into this place that doesn't pass, can we use this tool to get your landlord to fix or repair something to get it up to HQS? Or do we want to talk about the fact that if you move in, you may have to break a lease and leave once your voucher comes up? So it's a tool for us in FCS, and we hope that anyone that's housed has an HQS inspection in their file or an HHS inspection. A lot of times you'll be working with HUD or a CAP agency or even Commerce. So if that's the case, and maybe you didn't even house them, we would really like to see that inspection in the file for them. So that's a way to say we're asking the questions, we're having the conversations, we're documenting it, and whether they choose to stay in that unit or move into that unit, whether it passes or not, we have the conversation and we use this inspection as a tool. Safety is an interesting one. We don't have like anything to document that it feels safe, but I always say what feels safe to me may not feel safe to you. And so we can't assume that somewhere we might be trying to encourage someone to move into or talk about a unit. We want to have the conversation. Does it feel safe? Was it a place that maybe they used to use and they're in recovery now? Is it a place that there was trauma and now we're trying to get them to live there again? You could go see it on a Tuesday afternoon and it be super quiet and comforting, and on a Saturday night it could be the Wild West, right? So having that conversation about whether someone feels safe where they're living is really important, because it may differ depending on who we're talking to and what that might look like. And then affordability for any kind of supportive housing or affordable housing, we want people to be paying 30% of their income or less towards their rent. Right now, when I go out and talk to agencies, most folks, like the majority, unless you have a lot of direct connection to rental assistance, pay 50% or more towards their rent, right? And not everyone's eligible. And there's a lot of people on wait lists. So what can we do to get people connected? Are we using coordinated entry, even though it's a process? Is it a barrier? Sometimes, but we should be utilizing it. Are we looking at other options to pay rent? What else is out there? Are we talking about supported employment and how that helps somebody maintain their rent long term? Employment is so much more than a paycheck, but in housing, it can really help someone maintain it, not only for being part of their community, but also for paying the rent when they have a paycheck coming in, regular income. Integration is really about getting someone to feel like they belong in their community. And we already talked about that a little bit, and how important it is that someone feels like they are part of their community, not being an outsider, not having some sort of social network. We really want folks to have that, that natural support system is really important for housing and employment. And so we want to think about how we're doing that. For housing, integration really looks like, are we housing people in integrated settings, meaning out in the community in scattered site housing? Any one of us could sign a lease. We don't have to have any requirements other than maybe our credit score, but we can sign a lease in the community, right? With a mom and pop landlord, it doesn't matter. That's integrated as best you can for housing. But we have a lot of people that choose to stay in non-integrated, which is sort of project-based housing, low-income housing, transitional. Those all require you to have a specific diagnosis or something that makes you eligible, chronic homelessness. And so when you start housing people in those settings, how are you going to integrate people into their community when they are around the same people they might get services with? That's their community, they might take classes with them. So we have to think about how we're integrating people to become part of where they live, so they want to stay longer, because really it's about that permanent supportive housing. We want them to want to stay. Access to housing, this is going to be like, everyone's going to be like, oh no, this is housing first, this is low barrier housing, as we're going to call it, I think, in the future. Unfortunately, this is housing first. This is not requiring any kind of anything to prove that they need support or need housing. They say they want housed, they get housed, right? We don't ask them, do you have income? I mean, we'll help them get there. Do you have this or that? Are you sober? Are you still using? Well, that's part of maybe somebody getting stable, right? So maybe they need that place to lay their head to be able to do that and access that. Actually, in housing, if most of you come from housing or homeless outreach, we know a lot of people end up using just to be able to have a place to stay, to have somewhere to go until they can. And so it doesn't really help for them to get stable, or it doesn't help them to not be stable, to be able to do housing, employment. Maybe it's recovery services, maybe it's behavioral health. So making sure somebody has that place to live and not putting any prerequisites in front of that. One of my favorite responses in a fidelity review is when I ask, how do you know when someone's ready to be housed? And someone said, we were born ready, Kimberly. And I said, that's right. That's right. So if somebody says, I need housing and I've got these barriers, I still need housing, we're going to go ahead and start working towards that. And we walk alongside folks in both our housing and employment programs. Rights of tenancy, again, is just about somebody moving in, a lease in their name, as much rights to tenancy as we can get them. We know a lot of folks do live in recovery residence, Oxford, project-based, and there's additional addendums to the lease in those. As long as they understand what they're signing, that's fine, but it does take away from full rights of tenancy. So the more we can get people signing just a regular legal lease, then the better we can be for them to be able to stay and feel permanent in that. There's a lot of project-based or housing that exists out there that has a lot of rules tied to it. And so we want our participants to be fully aware of what they're signing up for. So when a landlord says, you get a 10-day notice for this thing, and they come to you and go, Jennifer, what did I do? Right? Or, what happened? I don't think I did anything wrong. You can go back and have that lease in their file and go back and say, this is what you agreed to. And yeah, traffic is a problem here, right? And so we want to be able to have leases in their file. Even if it's not a full legal lease, if they're in recovery residence or Oxford, where it's more like a house agreement, we still should hold copies of that in our file. We're advocates for them. And if we don't know what they signed up for, maybe we weren't there when they signed it. We need to be able to pull that out and say, hey, let's look at what you said you'd agree to and what your landlord said they'd agree to. So that's a best practice to have your lease or document in the file, but we really want people to have as full rights of tenancy as possible. And so making sure that they have informed choice about what that might look like. And sometimes that's hard in this housing market. I always say, could someone look at 3 different units before they get into a place, which we used to do back in the olden days. I'll say that again. However, our market looks very different than it did even 5 years ago. And so there may not be multiple choices for someone to look at, but we don't want them to settle just because they want a place to stay. So having that conversation, are you sure you don't want to continue to look? What is your long-term goal? Do we want to look at multiple places? What if there's a building that has 2 units? Can you look at both of them? Maybe one's a corner unit downstairs. Maybe one's upstairs, but kind of in the middle. We want to have those conversations and make sure that we are providing as much choice as possible for those folks. And I know it's harder in housing than it used to be just because of the market and the availability, but we want to try to do as best we can to support that choice. And the last one is flexible and voluntary services. And I don't want to say this is the last one, but it's the biggest dimension of supportive housing. Actually, it encompasses a lot of things. And really, this is about the types of services they're getting provided. Do they get options for what services they receive? Who's writing their service plan? Is that you, or are you just helping them figure out what their goals are? Right? So they should really be the author of their service plan, and they should be able to modify it. If I were to come into your agency and they've been served for a year, I would expect to see at least 2 service plans, at least. People change their minds all the time. We pivot. And so we should be documenting that in real time and using those documents as living, breathing things that we look at and review often to serve folks. We should have small caseloads. And here we go. Housing has even smaller than employment. We look at 12 to 15 per full-time employee. So some of you might feel like that's a shock. And for me, it was even when I first learned that, because I was serving like 26 plus when I first started doing housing. But really, to be able to serve someone well, do all the coordination we should be doing to support somebody to wrap around services, and do the documentation and maybe other duties your boss has given you. That's always in your job description, other duties as assigned, right? We want to make sure you have time to do that and still serve your people well, based on these principles. So 12 to 15 per full-time employee. Would never like to see caseloads go above 20, but it happens all the time. But that's the goal for good fidelity or for great fidelity. We want to think about how we're getting feedback from our participants. Do we have participant voice in what we do? Are you documenting using participant quotes? Are we seeing their voice throughout the documentation we see? Do you have a formal feedback loop that tells you what participants need and what does that look like? So we want to think about all those things. How flexible can you be in your scheduling to serve people? We can go deep dive another time, but I'm going to move on just for time's sake. These are all really important things to serving the population we serve and thinking about how they have a say in the kind of provision of the program. So for supportive housing, we have 2 sides to it. The pre-tenancy supports, everything you can think of that would help somebody get into supportive housing and tie it back to housing goals is a billable service. We do all sorts of things. We get birth certificates, we go get IDs, we get people on benefits, we help them develop community supports. We're always doing service plans to think about what their goals are. How can we stay intentional based on those goals? If you're in this work, you're probably a natural advocate. So that seems like a given, but it's on the list. We're working with landlords. We're not only working with landlords we already utilize, but we're learning to meet new landlords. How do we develop a community of landlords? We want landlords to love us so much that they want to call us and tell us that they have someone or a unit to house someone, right? If you can do that good landlord liaison work, you may have people that just call you and say, I got a unit. Who do you got? Right. And so building those relationships, not only building them, but maintaining them. I always use the Golden Girls, thank you for being a friend thing in this landlord thing. I think it's true for employment too. Treat landlords like you would treat a friend. Follow up, check in, see if things are good. What can I do to support you? Yes, I'm here for my participant, but I'm also here to make sure we maintain this relationship so my participants are safe living where they live. And I think that's the same to go for employment. And then we have tenancy sustaining services. You know, sometimes, and I say this a lot, and people are going to get sick of it, but I really think this is where sometimes the real work begins in housing, because we have folks that maybe have never lived independently, never had to take care of chores or bills or all of those things that now they're going to be responsible for. And this is sometimes why folks don't sign leases or get kind of fearful at that kind of, I'm almost close to having a house, right? We see sometimes people step back. It's because it's a commitment and maybe they don't know that they can, you know, follow through with that. So part of our job is to help them learn. What does it look like to pay rent monthly? How do we budget to make sure you have enough money to eat? How do you take out the garbage? How do you make sure your landlord's not going to be mad by, you know, I've had folks have hoarding behaviors. I've had people do things that would easily get them kicked out. Too many friends, letting your unhoused friends stay with you now that you have housing because you feel bad, right? There's all these things that we have to talk about. Learning boundaries. What is all the things that come to you when you think about maintaining your housing? And so we may be billing for some of those services to help those folks retain where they are living. Maybe it's relocating. Sometimes we know somebody's in a bad fit and we don't really want them to get a legal eviction. So how do we work with the landlord to try to transition them without that legal aspect, right? So maybe it's some of these creative skills that we do to help somebody either transition or maintain their housing, because if we don't come up with a solution, they're going to be evicted. So housing is the matter of being creative and tenacious. And I think it goes the same for all the work we do with folks, but really just thinking about how you think outside the box. These are billable services, but this is a short list. So think about what you're doing and how it's connected to their housing goals. All right, I'm going to take a sip of water and then we're going to talk about other programming. So I don't know how many of you are familiar with TAP. Does anyone use TAP already? Show of hands. I know it's hard virtually. TAP has been around since I think 2023. Okay, yeah, we got a few providers that are using TAP. Great. TAP has evolved over the years. As you know, if you've been utilizing it, it is a separate contract with WellPoint. So if you're a supportive housing provider, you do need to have an additional contract with WellPoint to be able to access the TAP funding. Kira, do you have a question? I see your hand up. Maybe you were just saying, yes, I use TAP. I'm not sure. So just making sure. I didn't want to like ignore you. So TAP depletes really quickly. As some of you may know, it's a program that it's state funded for people transitioning into housing. So it's for those things like deposits and application fees, and maybe it's they need their utilities arrears paid from their last place that they left. As a housing specialist, we know there's a lot of barriers outside of just being able to qualify for housing. There might be things from their past that may exist that make it a little bit more difficult. And one of the things I experienced often, and in those days did not have a lot of dollars to access, was the application fees. They're pretty expensive. You have to, you know, pay each one. There's no generic application you can use now. I mean, that's the dream, is that we can all just have a generic application and all the housing folks accept it, but that's not the case, right? So they have to pay for each time they apply for housing. There are some places out there that do exist that allow someone to get like maybe 2 or 3 applications in under that $45 fee, but it's not the rule, it's more of the exception. So we need some space to be able to help somebody transition into that housing. So there is a request through WellPoint that you can request dollars for an individual enrolled in supportive housing to access TAP funding. And so maybe it's just a justification for why they need it. There might be documentation behind that. Maybe it's a landlord's signature to say that they owe. But the reality is it's quick to deplete. So if you have folks that want to access TAP, you have to be contracted for one, and also be quick to the draw, basically, because it goes really quick. Luckily, we have some new funding going into the TAP bucket through HRSN, or health related social needs, that I'll talk about in a few minutes. So there is some additional opportunity to access funding for transitioning into units, but I will wait for that slide to come up.
Hey, Kimberly, just sorry to interrupt. Jerome, I noticed you came off mute. Did you have a question for us?
No, I do not have a question. I'm sorry, I didn't realize I was off mute.
Oh, no worries.
Sorry
right,
about
thanks.
that. Yeah,
Yeah,
no
and I know-
questions right now, but yeah,
All right. Well, definitely thanks for hanging in there and joining us today.
you
And I know there
betcha.
was a chat that somebody had a question for you, Kimberly.
Oh.
I think it was from Ben. If a client moves into a co-housing space where the person's room is separate from a communal kitchen or bathroom, how do we do these inspections?
Yeah, that's a great question. There are times when an inspection does make it a little bit more difficult because they're in shared living and it maybe not their unit. What I would say is if they're moving into their own room, even though they might have other shared living spaces, to do the best you can with just looking at where are they going to be living, what place are they renting. If you don't get to, it's okay. I would put an inspection in the file and say declined inspection. Participants have a choice in that too. So if they don't want to do it, we just need to document that they chose not to. So in those shared spaces, there may already be an HQS. A lot of those places are also renting or leasing and may have an HQS already done depending on the funding. But if you can't, or the closest you can get to like just inspecting the space that they are renting specifically for them, and document as much as you can there. Sometimes you can't get that's why fidelity is never a perfect score, because there's always going to be pivots depending on who you're serving, the choices they make, so you do the best you can and then just make sure it's documented why. Great question. Thank you. All right, I'm going to move into Apple Health and Homes. Some of you may have heard it called AHA. We like acronyms in our lives, so we like to make sure there's always an additional acronym you have to learn. Apple Health and Homes is a new department at the Department of Commerce, and we were legislatively mandated to partner with Department of Commerce on a new program connected to FCS. So what this does, and I'm going to go back to my old school housing days, it's the 3 legs of the stool. The idea behind Apple Health and Homes is that we're bringing the units, the services, and the funding together. So with Apple Health and Homes, there's funding, capital funding, so that providers who want to stand up housing can designate specific units they have to eligible Apple Health and Homes enrollees. We also had 2 lotteries already with some vouchers, the tenant-based vouchers. So I think we've housed about 120 people through Apple Health and Homes since it launched, through those vouchers that follow someone along. So they're not living in the Apple Health and Home units, but they are using the Apple Health and Homes voucher. So I don't know when the next lottery is going to be, but when you have someone eligible for Apple Health and Homes, it means that they fall under that 18 years older up, eligible for supportive housing under the first 3 risk factors. And I put in the quick reference guide into the chat so you guys would have a tool to just reference. Once they get authorized for Apple Health and Homes, they'll go into a pool. And when there's a next lottery, there will be a lottery based on region and how many people get pulled. And there will also be notifications through WellPoint that will tell you when one of our PSH providers have units available for Apple Health and Homes folks. And those are subsidized units built in. So those are ways to get someone access to Apple Health and Homes. It is a new program. It was legislatively mandated, and we're working really hard to make sure we get as many people housed as we can. Now, if someone gets housed under Apple Health and Homes because they were eligible upon moving in, they don't have to necessarily maintain FCS eligibility forever. So they could keep their housing whether they're receiving those FCS services or not down the road. If they lose Medicaid eligibility, maybe they go back to work and have income so that they can have their own personal health insurance through their employer. That would make them lose eligibility, but it doesn't mean they would lose their housing. Okay, so that's the Apple Health and Homes program. We're excited about it. I just went over that. I just skipped a slide. They do need to be experiencing homelessness. So that's one other factor to think about. This isn't for folks that are at risk at this time. We are prioritizing different populations. Whoops, I just went back. I apologize. So folks experiencing chronic homelessness based on our RCW for our state, which we already went over earlier today. And then the second population of priority are folks exiting inpatient settings. One of our state goals is to have earlier interventions, getting people into housing from exiting settings that have been more institutional. So we know that people get released upon, whatever duration they're there, sometimes right into homelessness again. And then we see that kind of people rotating through the system. And our hope is that through this programming, we can help instill earlier interventions and have better bridges to making sure people get housed upon release from whether it's jail, prison, inpatient. Our goal is to not lose people in that gap, right? So that's kind of the focus of this work.
Hey, Kimberly, looks like we have about 5 minutes left.
I know we didn't do, woo, okay.
So I thought maybe we can definitely send out the slide deck with all that information in it, but just kind of leave a little bit of time for any questions. You guys have been great about using the chat today, so thank you all for that.
Yeah, let us know. We can make sure you have more of this, and we do this once a month. So if you feel like you missed something, or you just want to meet one-on-one or two-on-one, because Darren and I love meeting with folks, be willing to contact us, email us. We are happy to join a call and just chat more. These are all things that we do all the time and would be happy to connect with you all. So questions are welcome, or thank you for joining us today.
Yeah, we definitely appreciate, working with providers who are thinking about, joining the FCS family. So, if that's something you're considering, please reach out to us so we can set something up. I know there's a lot of information today, and you guys were great about asking questions and hanging in there and sharing information. So I do appreciate all the great engagement today and great questions.
Yeah, somebody just asked about HRSN. So if you want to hang on just a minute, I can talk about HRSN. It's a new Medicaid benefit that came through our Medicaid Transformation Project 2.0. Some of this benefit is connected to the Foundational Community Supports Program. One that's already launched is the Transition Navigation Funds, which are really another bucket through the TAP program. So folks who are eligible for HRSN, and that means they're eligible for Apple Health and Homes as well, would be able to request HRSN dollars based on what their request is. And then WellPoint determines whether it comes out of TAP or HRSN. Currently, TAP is tapped out. No pun, pun intended, I'm not really sure. But there is still HRSN dollars there, but it does change that what's able to be paid for might differ just slightly based on requirements through CMS, because we're using Medicaid funds for that. The other part of HRSN is the 6-month rental assistance that we've been talking about for 2 years. We've been dreaming about it for a decade, but we did get approved to pay up to 6 months of rental assistance per demonstration period. We are phasing that in. So it's getting launched, I think, in April. I don't want to even give a date yet because I want to make sure that I'm positive about that. But it will be phased in as paying arrears at first. So somebody that is at risk of homelessness would be able to get some arrears paid for to be able to maintain their housing. And eventually it will be future rent. It does require a lot of tracking because we can only have somebody access it once in that demonstration period, and it might be accessed through different programming. So there is some listening sessions coming up, I believe, next week. And so I suggest if you're interested in the HRSN benefit, you join ANESA in learning more about the program. And I can make sure when we send out a follow-up that you get that link. So that's HRSN.
Looks like Ben has his hand up for a question.
Hey, Ben.
Yeah, I'll try to keep it brief. I just wanted to ask, can we bill our units for FCS supported housing and supported employment? Can we bill for the fee for service through the HRSN, or is it just for the additional programs?
I guess I'm a little confused. So FCS is definitely a separate benefit from
Right.
the MCO, so it's got a firewall. So you can only bill for services you're providing under someone who's eligible or who's been enrolled in FCS. It wouldn't be under your regular like peer services, or it's got different codes specific to FCS. Employment has 2 codes and housing has 1. And so you would bill those specific codes for these services specifically. The other thing I would mention is if you're trying to do FCS and you already provide case management, you want to think about, are you supplanting? So are you thinking about, are these services already available and we're just replacing funding, or are they getting a more intensive service through FCS?
Perfect. I just know previously when I worked for a boss, and had to try to help out with getting reimbursed for the services that we provided. I know a lot of the administrative challenges were getting paid for the services that were provided. And so I was just kind of checking in to see if that maybe is still something that you're getting from providers, like maybe back from WellPoint or anything like that. This might not be the place to have the conversation. I was just curious once I saw the HRSN guidelines pop up.
Yeah, I think reaching out and maybe talking more about it, but it's Medicaid. And so we have to be really informed about Medicaid services because they have very specific rules. And we are here to help guide you in making sure you're not trying to do something by accident or unintentionally that would affect your Medicaid. People do get audited randomly. WellPoint audits our programs. We do fidelity reviews to check in. And so utilizing Darren and I as much as you can in the early times of doing this. Let us come out and do fidelity after you've provided services for a little time, to make sure that we are the first ones that have eyes on it, so we can help you if there needs to be some training needs or some coaching or whatever it might be on making sure we're meeting Medicaid requirements. Because although we're a waiver, we still have to follow Medicaid, right? So
Yeah.
we were able to waive a lot of things, but not the Medicaid rule. So here we are in a weird space, but that's why Darren and I are here for you all.
Thanks so much.